a huge honor for me today to be podcast interviewing Dr. J. Elliott out of Houston, Texas, with TexasImplantEducation.com. Dr. Elliott is a 1980 graduate of the University of Texas Dental School in Houston. He has been in private practice there since. He completed a 3-year implant residency at Loma School of Dentistry in 2000. He is an honored fellow of the American Academy of Implant Dentistry and a diplomat of the American Board of Oral Implantology, Implant Dentistry. Dr. Elliott was a named plaintiff in a federal lawsuit against the Texas Board of Dental Examiners for the right to claim specialty status in implant dentistry. The court found in favor of the plaintiffs by summary judgment in January 2016. He's also the director of TexMax, the newest AAID-sponsored maxi course for implant education in the world. You know, there were the two largest stories in the last 6 months was that basically a dentist is telling the consumers, in all honesty, I specialize in implant dentistry. And the American Dental Association, which is not a government agency, was saying, you can't do that because we only recognize 9. And it went to court, and the judge said, the American Dental Association is a membership club. They're not a government agency. They don't say who's a specialty and who's not specialty. Did I summarize that pretty much?
Reasonably well. Yeah,
but
pretty much.
Before we start with that, I can't remember the last time I cried, but I cried yesterday when I found out that Carl Misch died. And I can't think of anybody who he had a greater impact on than you too. I mean, what are your thoughts on the passing of Carl, and how did his legacy affect you?
Well, you know, Carl's legacy affected everybody in implant dentistry. He was the titan of our generation in implant dentistry. There's no one out there that comes close to him that's under 65 years old. And we lost a tremendous spokesman and a tremendous thinker. And he's had more influence on more dentists doing implants out there, especially general dentists, than probably anybody alive. And it was tragic that he's gone. And I send my sympathies to his family. And he will be long remembered. And his impact will last as long as anyone he ever taught is still doing dentistry. It was tragic.
Well, we're gonna make a tribute the February issue of Dental Town magazine, the way magazines work. And if you want to send in any article or column or anything on implant dentistry, I can think of a finer guy to write it up and maybe even summarize this, because I thought that'd be a great article from you, because Carl was the first person in recorded history in America who limited his practice to implantology. He was in Detroit and he said, I'm just gonna do implants. He was first. Am I right?
I believe that's correct. I believe so. I'm not sure of that, but I believe that's correct.
Yeah. And I always think that when you get to a fork in the road and you don't know where your moral compass is, it's so easy to figure out. It's just what's best for the consumer. It's not what's best for the oral surgeons, the periodontists, or the American Dental Association. I mean, if I was a patient and I was getting the runaround, and this dentist said, go to this guy and place the implants, and go to this guy and get the bridge, and the lab was this guy, and it's just, at the end of the day, it's just not working. And then I found out that I could just go to one place, and he could place the implant, restore the implant, or fix an implant complication. Isn't that what would be best for the patient?
Yeah, and that's what the AAID has been all about since 1952. And you know, that's the essence of specialty, and the essence of the best service is to be able to do it all at once. But you know, dentistry got kind of schizophrenic in the late 70s, because prior to that, specialists said implants didn't work. And the reason that the giants in implant dentistry in the 50s and the 60s had any trouble at all was because of the material they were using. You know, Harold and Ralph Roberts designed an implant and sent it to Lenny Linkow, and Lenny Linkow took it all over the world in the 60s. But they were using chrome cobalt. They didn't have titanium. And so there were problems with them because of that, but they still worked. And then after Brandemark came along, and Brandemark had the academic credentials that the universities couldn't argue with, they had to admit that the implants worked. And then the shift came to where implants worked, but only certain people should be allowed to do it, and that's created a division in our profession that just doesn't have to be there, and it's been a tragedy, and hopefully going forward here we can fix that. So.
Well, I think these things are all related. First of all, it is a fact that Carl Misch's book on implant dentistry is the most sold dental book of all time of any subject.
Yeah.
He sold more units than that. It's also a fact that on Dental Town, we have 250,000 dentists who have posted 5.5 million times. And the most active of those 50 categories is not root canals, fillings, crowns. It's implantology. And it's also the procedure that's not done by the most dentists out there. So, I mean, they're doing root canals, fillings, and crowns, but most of them are not placing an implant, and they're reading the textbook. It's the most sold textbook. And when they go to Dental Town and they're confused about something, implants is the most place they go to.
Mm-hmm.
So you have been a legend in actually teaching people to do implants. So right now, I'm going to set this up for you. Most old bald guys like you and me read textbooks and go to dental conventions to learn. It's the millennials who like podcasts, online CE on Dental Town. So you're probably talking to mostly 30 and under, and they all say the same thing. They say, "Man, I just graduated from dental school. We didn't place one implant." And so how do you go from I've never placed an implant to where now I'm comfortable placing a single implant replacing the most common missing tooth and molar? How would you coach them to go from 0 to 1?
Well, I think the most important thing is the training has to be comprehensive. You know, the problem, I started out in implant dentistry in 87 or 88. I went to LSU and took a weekend course on an implant made out of something called vitreous carbon. And I thought that was great, and I bought the kit, and I did all that stuff, and I went home, and I put a few in, and they all fell out. In fact, the last one fell out. I put it in on a Friday, and the guy walked back in the office on Monday with it in his hand. And somewhere in there, I figured out that I really didn't know what I was doing. And the problem, most dental schools in the country don't allow undergrads to do hardly anything in the implant dentistry. So they get out without a lot of training, and then they seek what they think is the most important part of it, which is the surgical aspect. And that seems to be the most important to them because that's the part that they're the least comfortable with, the least experienced. So they think that that's what they have to learn in order to be able to do it. And I tell my students that implant dentistry is like an iceberg. The part that's above the water is what you think you need to know to be able to do it, but it's all the shit under the water that's going to get you in trouble. And so you need to be able to keep that top part afloat by knowing all the stuff at the bottom. And the problem with general dentists getting training is it's difficult to get training with live surgery. Most of the live surgery courses are in the Dominican or Mexico or someplace, and those don't really do you any good because you go somewhere, you watch somebody, you place some implants, you go home, you never see those poor people again. You don't take care of them. You don't understand how to manage their complications by your own experience. And I would say that the biggest problem is most of the training available to general dentists is simply too short. And it's a big program. I tell my students, implant dentistry, in my opinion, is the epitome of dentistry because you have to have surgical skills like an oral surgeon. You have to have soft tissue skills like a periodontist, and you have to have the restorative skills of a prosthodontist because you put it all together in there. None of these people come to want implants. Nobody else goes to your door and says, "I'd like an implant." They all want teeth. And anybody that's been doing this for very long as a general dentist understands that it's not that uncommon to have somebody come in with an implant placed someplace else and the implant's not in an ideal position, and you're the one that has to take the heat for that because you're the one that has to put a tooth on it. And when you can't put a tooth on it that looks right because the implant's not in the right place, then you get finger pointing between the dentist and the patient loses. So I would say that the first thing to do is to find training that is comprehensive enough to take care of that part of the iceberg you can't see.
Okay, well, your website is TexasImplantEducation.com. If my homies went to www.TexasImplantEducation.com, I assume they're going to find the biggest implants in the world because everything's bigger in Texas.
Is
that your claim to fame?
Well, no, we don't put large implants. I do have a little video about not actual size with an implant about this big, but the AAID has been are the leaders in implant education. That's been the driving force of the academy for 60 years. From the time when everybody showed up and shared in the 50s and trying to figure out what it's doing to today, the Maxi course is the biggest branded general dentist implant training program in the world. There's 14 around the world at this point, with 2 more in the pike. The Texas course, my course, is new. This is our first year of doing this course. West of here, it's Vegas. East of here, it's Atlanta. But what you get with the Maxi course and what you get with the AAID are that the good basic training. Our course is 300 hours. The Texas course has 7 days of live surgery on your own patients. So you have to live with those patients. You know, you treat them, and then you have to go home with them like we all do with all of our patients. You have to handle all the things that happen. What happens when sutures come out, or do you get an infection, or all those things. You have to actually be able to handle those things, and you learn that because they're your patients. You live with them. The other thing that you get from the Maxi courses is you get the requirements to sit for the credentials of the American Academy of Implant Dentistry. They are the only credentials in implant dentistry for general dentists that have been held up in 3 federal circuit courts. These are the real deal. These credentials aren't given out with a check. You don't mail in x-rays and get it. You have to take written exams. You've got to take oral examinations.
And what's that credential of the AAID?
Well, there's 3 actually. The first one is the associate fellow. That's the entry-level credentialed. That's the entry-level credential. The above that is the fellow, and in '69, the American Academy of Implant Dentistry created the American Board of Oral Implantology, implant dentistry, modeling it after the other boards at the time, the oral surgeons, etc. And the Diplomate of the American Board of Oral Implantology is the highest level credential that you can get, and it's been vetted in all these courts. The fact that I won this lawsuit in Texas was the 3rd lawsuit. We've been fighting since 1995 in Florida and California, and we've won all the way through the appellate courts in Florida and California, and then we came to Texas. So these credentials have been vetted at the highest level. I can tell you, I've been on the Admissions and Credentials Board for 6 years, and I've been on the Test Construction Committee for 4. We spend a fortune on psychometrics on these exams. These exams are not easy. These exams test at the highest level, and every single year the Academy spends a lot of money to make sure it's kept at that level. So that's why the courts have recognized them as being bona fide, and that's a large reason why we won in Texas this year.
But don't you think most people think that test is easy because I'm a fellow in that?
Well, Howard, once in a while one slips through. I mean, what can I say?
Man, I got mine so long. I think I got mine in '98. Diplomate in the International Congress of Oral Implantology, Fellowship in the Misch Institute.
Yeah, well, ICOI is not us.
Okay,
we're the AAID. Okay, the ICOI was actually started by Ken, Judy, and Carl.
Yeah, I did it all when I went through the Misch Institute.
Right. Well, that's a different organization and a different credential.
So was that before the AAID?
No.
Okay.
No. Ken and Carl started that organization.
Ken and Judy.
Yeah, and but the AAID's been around a lot longer than that. And our credentials, we've been around since 1952. We are the oldest implant organization in the world, and and the only credentials that have held up in federal court are ours. And that's why, as you go forward here, not only do you have the doors open, and we'll talk about later about the possibility for specialty status, but if you wind up on the wrong end of an attorney, in a wrong end of some sort of a complaint, these credentials are the real deal. And it's, as a general dentist, if you don't really have a lot of friends out there that aren't general dentists doing implants. The specialists as a group don't tend to, play well. And you need the help. You need the support. These credentials also give you the confidence that you actually do know what you're doing. These exams are rigorous, and you pass them, and you understand that you do know what you're doing. And by the time you get to the Diplomate, you know it at a specialty level. There aren't any other exams out there like the Diplomate and the Fellow in the Academy. None. The Diplomate's the written examination for the Diplomate, the multiple choice was the hardest multiple choice test I've ever taken in my life. And I'm proud that I passed it. And I wasn't sure I passed it when I walked out of there. So you get a lot with these credentials besides some sort of a certificate.
So to my homies listening right now, so you're saying basically the first thing they should do is go to AAID.com and join the American Academy of Implant Dentistry?
Yes. Every general dentist in the country now, and we have lots and lots of specialists in our academy. The diplomates, there's about 450 active diplomates in the world today, and 20% of those are perio-pros and oral surgeons. But yes, if you're a general dentist and you want to get plugged into the oldest, best organization for implant dentistry on earth, you need to be a member. And you need to work toward the credentials, because those credentials give you a structure for your training. If you're new and starting out, they give you a series of hoops to jump through that will ensure that you get where you want to go. And I'll tell you, it resurrected my career in about 95, because the history and the tradition of the academy is one guy helping another. You'd walk through the floor and you'd see Carl talking to some guy that hadn't been out of school a year, sharing with him and talking to him. Everybody, there's no agendas there. You can walk up to Hilt Tatum, Ralph Roberts, Lenny Linkhouse still shows up, and everyone there learned from somebody before them, and we all give back that way. And I've never experienced that in any other dental organization I've ever been in.
So Hilt went to what did he do? He moved to France, Hilt Tatum?
Yeah. And he's the course director for the Puerto Rico Maxi course, and he lives on an airplane. I mean, that guy is just amazing. I don't think there's a more accomplished implant surgeon that's ever lived than
How
Hilt
do
Tatum.
you you see him very often?
I see him once or twice a year,
Do you
meetings and
email him
stuff.
ever?
Sometimes, yes.
Well, tell him
Yeah.
I'd give anything to have him on the show. I think that would be so fun.
Okay, I
So
will do that.
So I do. I think it's amazing. So you say go to AAID.com, join that, and we're back to these millennials who we're trying to get to go to 0 to 1. They join the AAID, and you say first they become. How much does it cost to join?
I don't know. I
And
mean,
then
for a general member, probably about $300, and if you've been out of school less than 3 or 4 years, they have some pro-rateds to make it even easier for you.
and then you'd say first they should try to get their associate, then
Yes,
their
they
fellow,
need.
and then
My
their
advice.
diplomat.
Yeah, but the first thing, it's you eat the elephant one bite at a time, right? And the first thing you do is they need to take a maxi course somewhere in the country of the world. There's maxi courses at Loma Linda. There's maxi courses in Oregon, Vegas, Toronto, Vancouver, here in Texas, Georgia. There's one in New York. Howard is about to start one. There's a new one starting up in Florida, because this is the requirements for the associate fellow are 300 hours of implant didactic education as part of it. But the academy is very rigorous in what they will accept. And so if you don't take a maxi course, rule of thumb is you need to have about 500 hours of CE to get 300 hours that the academy would accept. So the simplest and cheapest way to do it is to just take a maxi course, because that satisfies the didactic requirement. Then you have to present cases. You have to present 3 cases in specific parameters and defend them in an oral examination, along with other cases that you don't see until you get to that examination. You pass both parts of that, and you become an associate fellow in the academy. That's why I say it.
And how so join the AAID and then sign up for a maxi course.
Yes.
And is that maxi course information on AAID.com?
Yeah, there's a link there that'll show you every maxi course on earth, and you can click to the individual websites for those maxi courses and find out everything you need to know.
And then yours is TexasImplantEducation.com.
Yes.
And so how much is that course? How long is it? Go over the details of that course.
My course is $23,000. It starts in November and it ends in October.
Starts in October and ends in
No,
November.
it starts in November and ends in October. We take December off and we take July and August off. This gives, and there's 7 days of
So it's
live
basically a
surgery.
year.
Yeah, pretty much. And
So it's
in my,
November, take off December.
Then it's January, February, March, April, May, June. Take off July and August, and then finish up September and October. And the last afternoon of the last day, you can sit for the written examination for the AAID. And so you walk right out of the course, and the last afternoon you take the exam, and so you've now got the written part of the exam finished. And all you have to do is get your cases worked up and ready and present them.
And it's when you say it's November and then it's take off December, then it's basically January, February, March, April. Are you talking like 1 weekend a month, or is it a
Yeah.
Monday through Friday, or
No, it's 1 weekend a month, a Thursday, Friday, and a Saturday, once a month.
a Thursday, Friday, Saturday, once a month?
That's my course. Now the other course is, Toronto is Friday, Saturday, Sunday. The different courses will have slightly different schedules, and they will have different starting and ending times in the year. They're all 10 weekends. They're 30 days, except mine. We're doing a new beta test on mine. We're bringing a lot more of the education. The AAID wants to bring a lot more of it online, so people don't have to take off as much time and travel time and away from family and everything. So I'm a beta tester for a large online component. So my course is only 9 weekends, and the other 3 days you're picking up, sitting around on your sofa in your underwear watching videos instead of having to travel to Houston to do it.
Whenever I set my lazy boy in my underwear with a beer, my dogs and cats all run away from home. I never see them again. That's how fat and ugly I am. Hey, this is I don't want this to sound self-serving, but Dentaltown has 250,000 members. I think the best marketing you could ever do is put some of that didactic on Dentaltown, so they're all going to see it, and then that will be your best marketing for them to find the AAID and the Maxi course. We put up 350 courses, and they just passed 700,000 views in 152 countries. So if you've already got the content, I'd repost it. I'd send me an email, Howard at Dentaltown, and the other Howard Goldstein's in charge of online CE, but so he's Hogo at Dentaltown. But my God, you guys, I see so many, like Invisalign. They have the best content in the world, but there's not hardly 3 dentists on earth that know that any of it's on their website. You know what I mean? So if you're Invisalign and you already got the courses on your Invisalign.com, put a couple on Dentaltown to drive them to, because I just want the dentist to learn this, because I believe that the more, if you're a restaurant, the more dishes you can serve, the more tools in your toolbox. I mean, my God, I mean, to me, implants. I don't think I ever understood removable until I learned implants. I mean, you don't understand TMJ if you've never done a simple ortho case. I mean, it's all this cross training, and after 10, 20, 30 years of all this cross training, you actually get really good at helping people keep their natural teeth as long as they can.
That's right.
So if you got all those courses, put some of them on Dentaltown, then end every one of them. For more, go to this website, go to your Maxi course, because again, on Dentaltown, of the 50 subjects that they search, I mean, we get to track every move they make on the website, so it's all data driven, like Google. And dental implants. The dental implants form for the month of December had 600,000 views. It's the number one, which tells me it's their number one problem. It's the number one textbook they buy. Half the dentists don't do implants. Half the dentists are. In fact, I want you to talk about this first. I want you to put your psychology hat on. You got 3 children, right? All girls.
Yeah.
So let's, when you and I were in dental school, there were hardly any girls. Now half the class is girls. There's a girl driving down the highway right now. She's going down Highway 54 in Kansas. She's got an hour commute to work, and she's saying, "Jay, I just fear this bloody stuff. I'd rather learn Invisalign or sleep apnea or veneers. I'm just frightened to place an implant." So you got to get them over the fear first. how do you get someone who just likes the clean and pretty stuff to turn into a blood and guts barbarian like me and you, who loves to pull a wisdom tooth, lay a flap, place an implant? I mean, I love it when I go to wash my hands and I see a couple of red drops of blood on my head. I mean, that's how I know I just had a rocking hot day.
I get to shaking if I don't pull enough teeth in a day. Well, Howard, that's a hard thing. We've talked about that in the academy as long as I've been a part of it, because there's two groups. That girl driving down the road is one of two people. One of them is, you're not gonna ever. They don't like it. You can't send a duck to Eagle School. If they don't like it, they don't like it. But the other ones are just simply afraid. It's when you go to dental school, it's all new and you got people holding your hand for everything, and you're young and it just happens. You get out of school and you start closing in. You start being more concerned and more afraid about new things. It's uncomfortable to get out of your comfort zone. It's scary to do that. And I think it comes down again to having mentorship, having a group that someone that'll take you by the hand and show you through this. The academy in the 50s and the 60s, the way implant dentistry started is you found out somebody did it and you got all excited. So what did you do? You went to his office. You made a pilgrimage, because that was the only way to learn. There wasn't anything taught anywhere, so you had to go find it out. And young general dentists today get out. They're told over and over in school that, basically, I hate to say it, but in my opinion, dental schools to a large extent teach young dental students how to refer. They're not allowed to do much. We did osseous surgery when we were in dental school as an undergrad. We did flaps for all that, but they don't do that today in most of the schools. And so they are scared, and they need to find an organization or somebody that will take them by the hand, and they need to make the effort to get bloody, get in there and look at it. Go find a place, find somebody. If it's somebody in your town, go hang out with them. Take a maxi course. Find a live surgery course that'll help you get over that. The other thing that happens is there's a lot of basic medicine that, as general dentists, we know, but we don't really know well, and that's another thing another wall that a lot of people are uncomfortable with, because the medical exams have to be better. The health reviews are more comprehensive in a lot of ways, and a lot of the things that the patients are doing or interact more with you from as a surgeon than they do as a general dentist, and things that we can kind of ignore or just kind of slide by, we can't anymore. And that's another big wall that I see for a lot of the young dentists. So basically it's find somebody and hang on to them and go for the ride, because it's a great ride. Most of the implants in the United States should be done by general dentists. General dentists, this should be as routine a part of a general dental practice as anything else. It should not. It doesn't have to be cloaked in mystery. It's complex. It's a complex treatment, but it's not out of our realm at all. It's what we do every day with just a couple of extra twists, and you just have to get in there and do it. Everybody in the country ought to be doing it. There shouldn't be a dental practice out there that isn't.
True or false? I mean, I'll see 30-year-old dentists working in corporate who pull teeth all the time, but they think it's harder to place an implant than pull a tooth. If you can pull a tooth, do you have enough surgical skill to put a tooth back in an implant?
Of course you do. Of course you do.
So if she's listening to you right now, if she can take a tooth out, she has what it takes to put it back in.
Yes. There's just training you have to have, and you have to get that somewhere that is competent. You can't learn it in a weekend. We didn't go to dental school for a weekend and walk out and be a dentist. We took years to do it. And one of the things that happens, and certainly the way I learn, I can throw a bunch of information at you, and some of it'll stick, but a lot of it won't. And I have to go home and think about it, and then come back and do it again. That's the way we learn. That's how dental school is. Of all the time you're in dental school, a whole lot of that time was wasted in a lot of ways. But it's part of the process of absorbing the data. In our course, I spread the 7 days of surgery out over March, April, May, June, September. It's over 5 or 6 months, so that instead of 4 or 5 days, people go to Mexico or the Dominican, they'll come home and they'll say, I placed 40 implants like it's a trophy on the wall, but it doesn't mean anything. They didn't follow the patients. They didn't follow through. And whatever they learned, they only learned at the level they could see. If you take your first ortho course, you're going to learn whatever you learn. But if you go back and take that same ortho course 3 or 4 years after you've been doing ortho, you're going to see and hear and learn other things because you have the capability to see and hear those other things because you've moved past the beginning level. And so we try to spread the surgery out so that you do one and you think about it and you talk about it, and then another month you do another one. And so by the time the course is over, you've had time to absorb more. And that's only the beginning. These courses, the Maxi courses, are fabulous starts, but they're only starts. You're going to have to continue on after that. But I think that the key is to put yourself in an environment of learning that will nurture you and protect you and take long enough that more of it soaks in. So you're not just, you don't take something and throw. I know I've got students that have been to Mexico 3 different times for a week and they're still not placing implants. And, you just got to have the environment to learn and the time to absorb.
So a lot of them, I got to talk about the business of this because they'll say, well, I don't want to take that ortho course with Richard Litt, who's a board certified orthodontist, because it's $5,000. I'm like, dude, your first ortho case is $5,000. I mean, you get your money back in one deal. I know when she was driving down the road and you said it's $23,000, she drove off the road. She's now in the middle of a cornfield and she blew all 4 of her tires. But what's the chance that if she gave you $23,000, that she would place 23 implants and get $1,000 back from each one of those? What's your success rate that if she signed up and gave you 23,000, the patients would pay her back 1 implant at a time and she'd place 23 implants? What's your success rate on that?
I think that success rate is almost 100%. There's very few Maxi course people that don't place. That doesn't mean there's not some. There's people that take these courses and don't place implants afterwards, but very few. Most of them do, and all of the credentialed people do, 100%. So I would say there's a 25% chance she won't do it if she's not committed to doing it, but 3 out of 4 will. Probably more like 4 out of 5. But I can't tell you that much better. I don't know.
Okay, so now she's sitting here, and she's been in her office. She's had her own office for 2-3 years, and she's got Betty Sue, the hygienist. She checks 8 cleanings a day for the last 2 or 3 years. What supply of patient cases? Because she's wondering, it's supply and demand. You're going to teach me the skill, but what's the demand in my office? What should I be seeing in my patients coming in my office for emergencies, toothaches? I mean, are you mostly teaching, would I need a lot of patients with ill-fitting dentures, and you're going to teach me how to put a denture on 2 implants and O-rings? Or is this just people that needed 3-unit bridges? I would be doing an implant. What cases are realistic that I go to your institute for a year? What should I be already seeing a supply of in my practice that you would give me another tool in the toolbox to fix?
I think that depends very much on your practice. I've got 2 locations. I started a second office. I opened a second office 2 years ago across town. And those 2 offices demographically are completely different. The practice I've been in for 35 years, I do lots and lots of dentures, lots and lots of removable. The new practice has very little. So I would say that you take whatever you've got and you look at what's there. Of course, if you don't have a lot of removable, then the first thing you're going to see out of your patient base are going to be the missing teeth that you're doing partials or bridges on right now. The other thing that's really strong for a young dentist to be able to do is reconstruct the alveolus. The best way to be able to start generating more implants in your practice is to be able to take a tooth that's got a large abscess, that the buccal plate is gone, and to be able to restore that for the implant, because that's a smaller procedure that, in my experience, virtually no one that we graft the socket or reconstruct the alveolus, they all come back for the implants. So that's where I recommend that they start. It's whatever missing teeth that are already in there, but they have to have the ability to rebuild those sites. And lots of times those are individual sites. Very commonly it'll be congenitally missing laterals, or it'll be an abscess molar with this huge defect. When they can put those back together, then they create their own, they grow their own implant practice. And then you can market beyond that with removable, if you like to do it, or it's in your neighborhood. I think that the fastest way to grow an implant practice is to market a removable practice. That certainly worked for me.
Do you think Tiger Woods could beat you in golf using any golf clubs found on Walmart? Or, I mean, do you think Tiger Woods beats you because he has a better club? Meaning, do you think these kids focus way too much on what implant system that they're going to get? When a guy like you or Carl Misch, I mean, you could successfully probably use how many systems?
Well, they're all essentially the same.
So is that missing the point about what is the implant?
And one of the problems we have, one of the problems that I see in the country right now, there's a lot of corporate. It's all corporate driven in a lot of ways, especially the people that aren't doing it. You know, the companies will spend a lot of time telling you that their connection is the best, or this coating is the best, or the angle of their threads is the best, and none of that really matters. Those are nuances that as you get better and better will make a difference, perhaps, but it's not the implant system. It's they all work. They're all titanium today, with the exception of the ceramics that are coming out and all like that. They all work. Pick one that's cost effective and start using it. The main drive for the implant systems that I tell my students is it's the prosthetics, because that's it. You find a system that you like the prosthetics on, that you're comfortable with, and you can provide what you intend to provide, and you don't have to change. You know, the companies are always changing parts and pieces, trying to woo me away from mine and you away from yours. And I tell my patients, you know, an implant system's a lot like a wife. By the time you get one figured out, starting over is expensive and painful, and I just don't really want to do it. And so they're constantly reinventing everything, trying to entice people, and you don't have to do that. You can find an implant system. You got the prosthetics down. You don't ever have to change it, and you don't have to spend an arm and a leg for it.
The best thing about my divorce is now I don't ever have to worry about retiring. You know, I just don't have to think about it anymore. So is there primarily a system you recommend if someone's listening and say, yeah, but name a name, I want to get a system? Is there one you like more than others? Is there one your Maxi course teaches or recommends? Or
well, the Maxi course this year we're using 2 in our Maxi course. I intentionally don't recommend an implant product per se, because the Academy, my philosophy and the Academy's philosophy for all these years is we want to teach you implant dentistry. We don't want to teach you how to place a particular implant. I want my students to come out of there having been exposed to as many as they can, and understanding that that whatever the companies say, they can go to other implant companies. This year, the two implant sponsors for my program this year are Neodent and Implant Direct, and
Neodent is owned by is out of Brazil. That's owned by Straumann.
Yeah, Straumann now, right?
So that was
right.
Neodent's the biggest implant company out of Brazil, and Straumann bought them, and then they bought. I mean, yeah, was it Straumann who bought them, and then they bought the Megagen out of Korea.
Yeah, they're buying up all kinds of stuff.
And they bought someone in Israel too. Who'd they buy in Israel?
Miss? Did they buy Miss?
Is it MIS?
Yes. Yeah.
What does that stand for?
I don't remember. I don't
anyway,
remember.
So Neodent, and the other one is Implant Direct.
Correct. This year.
With Jerry Nisnik.
What?
With Jerry Nisnik.
Right. Well, I don't think Jerry's all that much of a part of it now, but
he was the founder, right?
Yeah, that's right. And you know, the thing, I picked those 2 companies because Neodent provides things that I like. I like a subcrestal implant, I like a platform switch, and I like a solid abutment. And they have all those. Implant Direct has the prosthetics for everything on earth. They have a good cost price point on their implant, and students that are coming in that have restored a few implants or placed a few implants with whatever system, my thought was they can be prosthetically comfortable with Implant Direct because just about anything they've done, they've got a piece for. And that's the way I've started it this year. Next year, I could have two more companies. I don't want to tell anybody what implant to use. I want them to be able to understand the differences in terms of cost, because that's the primary difference, and in terms of support. I chose companies for mine that have a big enough footprint that they can support these beginning dentists. There's some companies out there that are more boutique style. They're smaller, but they don't have the boots on the ground to help somebody in Amarillo, Texas, when they need help. So I wanted to pick people that could deliver the support afterwards, because that's what the beginners need.
I want to ask you a critical mass question. I wouldn't want to go get a hernia operation or a root canal if the person doing it didn't do a hernia operation every week. It seems like you always know what dentists are doing, because they're always talking about bonding agents and composites and root canals and sealers, because they're doing that all the time. But you notice when you switch over to dentures, 80% of American dentists, they only do like one denture every 6 months. And you never hear of them talking about a new denture technique. And they're always doing the same denture technique they were taught in dental school, because they don't do enough of them to ever think about it. And then every time they go to do a denture, they're always thinking, okay, what do I need again? A bowl of hot water and that wax ram, and the assistant's all like, so what is the critical mass implants? For me, when I tell these kids, when you get into placing implants, you need to place one implant a week. If you're not placing 50 implants a year, do you agree or disagree? I mean, can you really reach critical mass like a dentist does with a single unit crown, an MOD composite, a root canal? I mean, would you really want a guy doing an implant on you who placed 2 a year, 3 a year, 1 a quarter?
Oh, no. You've got it's. I think that it's a power curve. It's not a bell curve, and it's not a logarithmic function. It's a power curve. In terms of how much difference does the next implant you place make in your ability to place an implant? You place 2, 3, 5, 10. The next 20 are going to be a big deal. The next 100 will be a big deal. Now, somewhere around 400, 500, 1,000, somewhere in there, that's going to plateau off. And the difference of that implant and the last 10 you did aren't improving you very much. So the faster you can get up the slope on that power curve, the better you're going to be quicker. And my experience personally, and with a lot of my students, is simply, first of all, they're not comfortable doing it now. They get the course. We go through all kinds of case presentations and treatment planning, because the secret of implant dentistry, the general dentist has to be the director. And the problem over the years is the general dentist comes out, they don't really know, they don't do implant surgery, they don't really know all that much about it. So what do? They refer to a periodontist and oral surgeon, and then they ask the periodontist and oral surgeon how to run the case. And I tell my students, no. I don't care if you do all this or not, but it's your patient. You have to know what needs to be done, pick the parts of it you're going to do, and be able to judge the quality of what you got from anybody that you referred out. And so the faster you do it, the better you're going to get. But at the beginning, they're not sure, and it's going to be slow. The first part of that slow, very often in my experience with my students, is slow. It's a rare situation that they go from never placing one to placing 5 or 10 a month very quickly. I think that all depends on their personal drive and what kind of practice they've got. But they need to be doing it, and they need to be treatment planning it, and they need to be able to fit it into a schedule so that they don't have to stop the whole friggin' world. And just like if somebody walks into your office with a broken tooth that you weren't planning on at 4 o'clock, well, you can do the crown. It's not something you have to stop your entire office and change everything around to do. They need to be able to work basic implant dentistry into where they can fit it into a couple of hours. They can fit it into a spot where they can do it. And then, then they need to do as many as they can, as fast as they can, and just be honest with the people at the beginning. Look, I haven't done this. You may not want to, I haven't done very many of these. Discount the price and do them. People, if they trust you enough to come into your office, they'll trust you enough to do it. I have not ever found that to be a problem. I got two of my kids in my practice with me right now, and
Two
one
of
of
your
them's
kids
on.
are dentists. Two of your three daughters are dentists.
Two of my three daughters are dentists. One of my son-in-laws is a dentist, and my wife's a dentist. So you can guess what
Holy
we.
moly!
My third daughter manages the second office, and she's the course administrator for Tex-Mex. So yeah, we're all dentists, and my son-in-law's only been out of school since May, and he did an immediate extraction, immediate placement on number 8, 2-3 weeks ago, and they just got to get out there and do it.
Can I ask
And
how old you are?
I am 62.
Damn, you're looking good, buddy. That is so cool. Because I want to go back because you got out of school in '80, right?
Right.
And this 2016, so you're 62,
Yeah.
and you started. Your first one was a vitreous carbon, and we
Yeah.
don't do that anymore. Some of the initial implants were cobalt. LSU, that was the controversial. Who was that famous guy, Kent, placing those that artificial TMJ disc?
Oh God.
Remember
I don't.
LSU?
Yeah.
Was it
No,
Kent?
I can't.
And he was
I,
putting.
I don't think
But
I
anyway,
know.
a lot of pioneering stuff from LSU for the years. I was wondering what are your predictions that's pioneering in the future? Because on Dental Town, what I like on Dentistry Uncensored to talk about things. Not I don't like talking about anything that everyone agrees on. I like talking about the stuff that no one can agree on. A lot of people are saying, "Hey, these old boys think the best implants are the longest implants, so they want to get a 2 foot long implant in there, and that's why they're having to move inferiority over nerves. That's why they're getting paresthesias. That's why they're doing all these sinus lifts, and the implants are trending towards shorter and fatter, and that those implants don't need to be that long, and that most of the stress is in the first 4 or 5 millimeters. And I'm this excites me because anything that's pro short and fat, I'm all behind. I don't like anything tall and skinny. Are implants trending short and fat? Is that a fad or is that the future?
No, I don't. I don't personally think it's a fad. I mean, I know that I am going shorter and fatter a lot more now,
Is this
in
something
all
your
kinds
wife
of ways.
told you or your
Yeah,
your
yeah,
children?
yeah. But I'm finding that I'm more and more now going to shorter implants, subantral, instead of doing. I don't do as many lateral sinuses as I did. I am trending toward the shorter implants. It's easier for the patient. It's cheaper for the patient, and so far I'm not having any real issues with that. Has been advertising short and fat since they came out in the 80s.
How
They have
how short and fat are you talking?
my shortest implant 6 millimeters.
And
Okay,
you're doing a lot of maxillary first molars with 6 millimeter short fat implants without a sinus lift.
a lot of them, not a lot of them, but I'm doing a fair number now. I'm putting posterior maxillary implants in, yes, 6 to 9 millimeters. Whereas before I would do a lateral and they'd be 13 millimeters or 14 millimeters. I am going shorter and fatter. I don't know how many I've got out there, but I am looking now. When I see a situation like that, I'll have a conversation with the patient and I'll tell them what I can do. And I'll tell them that, we can do the graft, or we can get a bigger implant in here, or we can do the smaller one. And more they're saying yes to the smaller one. And I haven't had any real issues with that. Now I don't
With
have
6 millimeter.
yeah, now I don't have 1,000 of them out there for 10 years either. I don't have the Bicon history, but I'm not having trouble with them at this point. No.
I want to ask you the absolute most controversial thing in implant dentistry, and you'll be perfect to ask this because you're 62 and your daughters are millennials. It seems like everyone over 50 freehands the surgery. Everyone under 40 has to have a surgical guide. And
Yeah.
those guys, the older guys are saying, look, I've done 5,000 implants, and it's the same thing with a CBT and a pano. There's guys out there that place 5,000 implants that were born and raised on a pano, and they're like, look, I did 5,000 with a pano and no surgical guide. Don't tell me I need a CBCT and a surgical guide. So where do you weigh in between guys that say, hey, go in my charts, find 1,000 implants placed with a pano, no surgical guide, and the young guy saying, if you don't have a CBCT, and you've lived in courts as long as anybody fighting this dental implantology specialty. When you go to a Texas court, would you ever show up and say, "Hey, I placed 1,000 with the Pano no surgical guide," or would the courts say to you, "Dude, you need a CBCT and a surgical guide"? What are your thoughts? What I like to do is throw out so many questions, knowing that they all suck, that one of them will be good enough for you to bite on and answer.
Well, I would separate surgical guides and CBCTs at this point in time. My opinion right now is, and in my courses, I require CBCT. Yeah, we did them on panos forever and ever, and PAs even. But if one of my students winds up in court today, I think that you're just asking for too much trouble not to have the third dimension. And I have seen the great advantage of the third dimension, especially in the mandible, is there are all kinds of really bizarre posterior mandibles that look absolutely normal and wonderful on a two-dimensional pan and look like shit on 3 dimensions. So I think that it's my opinion that CBCT, in my practice, I don't do anything now without CBCT.
Okay, let me stop you right there for you go to surgical guides, because the other question they're asked about CBCTs is, who would want to buy a $100,000 cell phone then have to use the damn thing for 30 years when everyone knows every 5 years the next version of the iPhone and the cell phone is so much better? Do I really want to own a CBCT? And isn't it going to be kind of a dinosaur in 5 years? What would you say to that?
Well, I think for the basic stuff that we need, the CBCTs that are out right now are good enough. Now, will there be great advances and you'll be able to do other things with them and you wish you had it? Yeah, probably. It's just like the phone. But the fact of the matter is, the old phones still work. And you can still get a flip phone and you can still call somebody with it. The CBCT in my office is about 7 years old. I had a complex motion tomograph before that, which was a real dog, but it was the best prices I could get. And if you're in a large metropolitan area, you can send it out. Here in Houston, we've got a couple of companies that have their radiology chains. And for the first, when I finally gave up with my complex motion tomograph because somebody walked in with an ICAT disc, for years I referred out when I wasn't doing enough to justify the cost. I sent them somewhere else for the scan, and so I think you can do that. And if you're in a smaller town, you're stuck with that. But there are used machines out there now. What you really need for the CBCT is you need that width. That's really all you need. You don't need to be able to do stents. You don't need to be able to virtually place the implant. You don't have to do any of that stuff. You need to be able to see where you're putting it though. And I think that any of the systems that are out there now, if you've got enough of a cash flow to justify any of it, I think that you could keep one until it wears out and you'll be fine. I don't think there's anything that's necessary that it has to change that much.
Okay, now wade into the murky swamp of surgical guides.
Okay,
to prepare to piss off half the people listening to you right now, no matter what you say.
and that's fine, because I have opinions on surgical guides. I teach. The long and short of it is, I think surgical guides. When I say surgical guide, I'm talking about a drill guide. Okay, I think for most cases they are completely unnecessary, and they add a large level of expense and complications to the treatment. There are certain situations where that's not true, but for the most part, they are. And that's my opinion. I tell my students what I want for all the surgeries we do. I want a bullseye guide, because remember, this is all prosthetically driven. This is not. Implant dentistry is not a surgical discipline with a prosthetic component. It's a prosthetic discipline with a surgical component. And so what you want to do, whether you place the implant or it comes from somebody down the street, is you want that platform in the middle of the bullseye. And I tell my students, if we put a target on the wall and 5 of us stood back in a room and shot arrows at the bullseye and we all hit the bullseye, those arrows will be going at different angles, but as long as they come out in the bullseye, you can restore it. So I think a prosthetic guide is essential, especially as a beginner. But I think surgical guides, especially as a beginner, create a dependence on something artificial. Surgery is a dynamic event. No matter what you do, no matter what happens, in surgeries from time to time, shit's not going to go the way you planned. It's not going to look like you thought it was. It's not going to be there. So you have to be able to adapt. And in my opinion, the best way to do that is to do the drilling freehand. Flap everything, at least through the crest, so that you can see it. I'm not a fan of flapless, again, for beginners. These things are marketed to people that are uncomfortable. They're marketed to people that are uncomfortable laying a flap, and it sounds safe. A small implant, a little hole seems safer to drill than a big hole, and if you don't have to make the gums bleed, that feels safer. But it's not. You need to flap it, you need to see the architecture, and you need to drill freehand. That will make you a better surgeon. And then as you progress, if you want to do guided surgery and drill guides for situations, that's fine. But your average general dentist, as you're talking about, they're young, they don't have a lot of money, they don't have a large practice yet, they're trying to get going. If you keep adding layer upon layer of complexity and expense onto doing this, they're just not going to do it. And people and our patients are going to suffer because there's a whole lot of people out there that need the implant, and they can get them without surgical guides. Surgical guides are driven by companies that sell surgical guides.
Imagine that in America. Imagine money's the answer. What's the question? I'm gonna get you in big trouble here. I'm gonna try to throw you under a bridge 3 different ways. Is this a true or false question? That the number one cause of implant failure is when they don't go to a screw retain, but a cement retain, and there's excess cement, even though that excess cement says dental implant cement and has the ADA seal of approval.
No, that's not my opinion.
That's not
I've
your
been
opinion.
around. That's not my opinion. I don't believe that's the number one cause of implant failure. I think the number one cause of long-term implant failure is occlusal overload, and that's a blood supply issue. I've been doing this long enough. When I started out in my training, everything was screw retained, and I can't tell you all the agonizing times I spent drilling through crowns, trying to find screws and all that kind of stuff. So then the pendulum swung to everything cement retained, and now the pendulum is swinging back. Is cement a problem? Sure, it can be. It's mitigated with a platform switch. My experience is the tissues are much tighter around the implant with a platform switch. It takes a certain amount. You need to take X-rays. You need to check for this stuff. In my practice, cement problems aren't non-existent, but they're they're not a great source of my troubles. My troubles long term, when I get an implant that comes in that's been in function for a while that's not doing well, it's occlusion. So
just covering our bases. You're talking to a lot of people around the world. A lot of people don't know what you meant by, you just said mitigated by a platform switch. What is a platform switch, and how would that mitigate?
Platform switch is where the abutment is narrower at the top of the implant platform than the implant itself, so that you get a situation where the implant comes up and then it narrows and then comes out on the abutment. That narrowing, it allows for a much tighter. You don't get real attachment, but that allows for circumferential fibers that are denser and tighter. And in my experience, that helps prevent cement invagination to places you don't want it to go. Does it stop it all? No, but it helps mitigate that a lot. The tissues are much denser and much tighter, and I don't have a lot of problems with the cement. And I think, dentists at the beginning, and I learned on Dr. Tatum's system. Dr. Tatum had a FDA approved titanium root form system 2 years before Brandemark in this country. And I cut my teeth on that system. And in Dr. Tatum's old system, the abutments cement onto the implant. Once the abutment was on, it's not retrievable in any way. And then you prep it like in its standard crown and bridge. So I grew up that way. Having the ability to retrieve it, that's nice. And one of the reasons people say, well, why do you want to take it off? And one of the answers is because you can. So The pendulum is swinging back to screw retained, but I don't think it will stay there. I think that's going to be a swing, an oscillation that's going to continue to go with the generations, and I don't think it's as bad as other people say.
So you would say that the number one cause of implant failure is occlusion. That's what you just said.
That's my opinion.
And so
And
is
that's
that so would you say that when the young dentist is thinking about which one of the 175 implant systems I could buy, that's not the issue. The issue is that they diagnose and treatment plan, and a bruxer, a grinder. How would you prevent less failures from occlusal overload? Is it diagnosing and treatment planning?
Yeah. And then in the prosthetics, of course, traditionally you make the platform a little narrower. You don't have to make it as wide as the full tooth. Remember, teeth compress when the person clenches or bites. The teeth compress and the implants don't. And so if you don't have the implant lighter than the adjacent teeth, if it's a single tooth, for example, then what will happen over time is you're overloading it. As teeth wear over some years, you will get even more overloading on it. So it's important to check the occlusion regularly, like check it yearly. And there's some good products out there. The TechScan is something that I use now that I really like because I have another handle on the occlusal forces. But even without that, just check it. Make sure that it's light, and don't think it's going to be stable forever, because it's not. When they come in for one of the recalls, look at it. The ones that you don't, those are the ones that get me. And then of course there's problems with implant placement. When you get an implant that's not properly placed, you got cantilever forces, you got other issues like that, and that's going to happen sometimes. But for the most part, it's occlusion. I mean, every single way. I think that's all of it. And Joseph Chokrin out of France will tell you that the occlusion problem is actually a blood flow problem, because that extra occlusion is compressing the bone around the top of that implant, which is impeding the blood supply. And I think that makes sense. I think there's something to that. So.
Oh, and you promised me an hour, and gosh darn it, that I'm already 2 minutes over. Can I ask you any overtime questions, or do you got to run?
Sure. No, you go ahead.
Another thing they're on Dental Town asking a lot is they're very very confused about perimplantitis, because more times than not, here's what they're saying. They're saying in school, don't place an implant on this guy because, man, he smokes, drinks, cusses, and Irish, and you need to do it on a non-smoker, a good old American boy. And they're like, well, they've never been to my town. All the people that need implants lost their teeth and have dentures, smoke, drink beer, and watch football. And now this guy's got this implant in there, and he loves it because he can go to McDonald's and eat a cheeseburger fry. He loves it, but half of it's just perimplantitis and mush. But the damn thing's solid as a rock. It's not causing any pain. And then they're like, well, is this sending bacteria all over the body? I mean, do I got to sell grandpa? I don't care. It doesn't hurt. You got 7 millimeters of bloody mush around this implant. And even though you can eat steak and tater tots, you need to pull this thing out. So I know that was a lot of questions. So let me be more specific. Everyone they said you don't ever place an implant on is all the ones in my practice that need an implant. Right. And then when we put them in these smoking, drinking, cussing people, when they get perimplantitis, doesn't bother them. They're still eating French fries at McDonald's. So how do you address all that? I mean, do they smoke and drink in Houston at your denture clinic?
Yeah.
And you place implants in them?
I place implants in them. They'll get some sort of a sermon about it, but I've been doing this a long time, and I don't believe there's a single person out there that'll ever quit smoking because I ask them to, period. I walk in with that bias. I think that, there's a couple of groups that lie to you all the time, and smokers and diabetics are two of those. They'll say they're going to quit, or they'll say their blood sugar's controlled, and it's not necessarily. And smoking will impact the long-term health of the implants. But that being said, I've got implants been out there 20 years on smokers, and I've seen implants that have been. My mother-in-law's got an implant that was placed in Chicago in 1980. And she smoked for most of her life, and it's still going. She's 90. She's not smoking now, but it's still in there and going strong.
What age did she quit smoking?
Oh, probably 88. I mean, not long, last few years,
I
but
mean,
not, no.
I'm in Phoenix. I literally have patients that halfway through a root canal say, "I'm sorry, I said you got to go to the bathroom. No, I got to go out and have a cigarette." And they're out there in front of the office with a patient napkin on, having a cigarette halfway through a root canal. I mean, that's real world.
I have my patients, uh, I give them one of the waivers if they're smokers says that they acknowledge the fact that the smoking is bad for the implant. It can affect the surgery. It can affect the long-term health of it, and they understand that, and they sign the piece of paper, and I go on with it from there. I don't not treat them because I think that's silly. I wouldn't have half the practice I've got either.
Okay, so then the second half of that question is now this smoking, drinking, cussing, I assume Irish or Russian guy comes back to your office and he's got perimplantitis around it, and there's some people out there in the oral health, total oral systemic health region saying this bacteria is ending up all the way throughout the body. It's in the brain, the lung, the pancreas. You can't have it. You got to fix this. Perimplantitis even means extracting the implant and replacing it. But now you're trying to convince grandpa who doesn't have a problem in the world, loves his implant, but he's got perimplantitis. What would you tell that
Well,
kid?
you're making. I'm not sure I agree with your premise that the reason he's got periimplantitis is because he smoked. But that aside, you got those same issues with systemic problems and bacteria with people with all these nasty teeth that we see walking around with them. So I'll treat the periimplantitis. Is what I tend to do, especially if it's early enough. I don't. Uh, that's what I do in my practice now. Is I attempt to treat it and not take out the implant. I don't want to take out implants, especially if they're integrated. That's a lot
So
of
you're
work.
treating perimplantitis just like the periodontists used to treat periodontal disease around teeth?
Kinda, yeah, yeah. I do a flap. I debride the area. I degranulate it. I'm using PRF right now. I passivate with Flagyl and clindamycin on the implant for a good 5 minutes. I don't have a laser that I feel comfortable using in that, or I would probably do it that way to kind of disinfect it. I graft with irradiated cancellous bone mixed with PRF. And another trick I got from Dr. Shokran is I mixed a little metronidazole into that graft because he had some very interesting histology hinting that a lot of the graft problems are anaerobic bacteria problems. And so I've had very I've had success with that protocol quite a lot. It's not perfect by any means, and I don't anybody have to think that I'm saying that, but it works pretty well, and that's my first line. That's what I do
Well,
first.
I can't believe that you honored all my homies by giving us an hour of your life today and coming on the
Uh,
show. You were talking to Dennis from Kansas to Kathmandu. Also, my God, I'd do anything. I'd walk to Houston to get you to create an online CE course on Dental Town on this stuff. I think I'm a businessman. I think it'd be the best marketing you guys could do. I think what you guys do is amazing. I think you're in the most difficult area of dentistry, is proven by it's the most viewed on Dental Town. It's the most sold book, and it's the number one procedure most dentists will not do. And it's pioneers like you who are getting kids to learn how to do this and enter the world of implantology. As I really applaud what you're doing. You're a legend. Um,
well,
seriously.
I appreciate that. At this point, I was diagnosed with prostate cancer 2 years ago, and so I went through. I'm going to get a plug out now for all the guys out there our age. I found the best place in the world to be treated. It's non-surgical. It's Michael DeToli Cancer Center in Sarasota, Florida. All he treats is prostate cancer, and he has the highest published cure rate in the world. So, and anyone out there that's hearing this,
What's the website?
his name, it's the DeToli Cancer Center, and
Spelled
his
Datoli. The D I
D A
T.
D A TTOLI, I think. I can't. There's two T's and one L, or one T and two L's. I don't remember which.
The Datoli Dattoli Cancer Center.
In Sarasota, Florida, highest published cure rate in the world, and it's non-surgical. And he certainly not only saved my life, but a whole lot of other people out there. And one of the problems with men is we don't talk. A woman goes to the doctor, she finds a lump in her breast. By the time she's out of the parking lot, she's called three friends, and they've given her the names of 10 other people. So she has a network. Men don't talk. I was amazed at how many people that were in my life, in my sphere, in one way or the other, that had the cancer or had lost someone with the cancer, and I didn't know about it when I needed to talk. So I made up my mind that I'm going to be a source. So any of your listeners that want to reach out to me about this, I'm happy to share it. Datoli is the best place in the world to go. If you're even considering treatment or had a scary diagnosis, just go talk to the man. It's the best place in the world. But because of that, yeah, back to what you were saying, I really do appreciate that, because my intent for the rest of my breathing years, my kids say they're not going to let me retire, but all I really want to do is teach. I want to teach dentists, my kids' age, the young dentists, how to do this, because I want general dentists to do this like they do crowns and root canals. I don't want it to be a special purview of anybody. I think it's bread and butter dentistry that our country and the people need desperately. You can change lives when you put 2 or 3 or 4 implants on the bottom and snap an overdenture. That changes a life, and I want everybody to be able to do that. So,
are you friends with Dr. Datoli?
Yeah.
Invite him on the show. Invite him on the show. Tell him half the show's men, and they're all dentists. And they all got patients that have this. I mean, so the women dentists could be talking to the average dentist listening to this has 2,000 patients. Well,
Datoli's, he's also, I think, the most published guy in the world when you take lay, peer-reviewed and lay journals. So I will certainly send that out to them, because that would be a great forum.
I never have to worry about prostate cancer, because after the divorce, I have nothing left down there. It was all lost in the divorce. There's nothing. My gosh, and also, I just think, like I say, you have the hardest thing. You're teaching the procedure they're most scared about, they're most overwhelmed about, and it's so funny because when we're all little kids, I remember when everybody was like in the first, second, third grade, boys, girls. You ever ask them, "What are you going to be when you grow up?" It was always fireman, policeman, teacher. I think deep down inside, all humans love to teach. And I can just tell that you just love it. You just love teaching. You love seeing students learn and be better.
It's the way that I can give back the most. Implant dentistry changed my life. When I finally started doing this, my whole, I don't know where I would be in dentistry. I was burnt out. I was ready to go do something else. And the academy showed me a group of people that cared about each other. And implant dentistry has changed everything about my life. And I want that for anybody that wants it. You got to want. You have to reach out and grab it. It's there. It's not something that's going to be handed to you, but it's available for anybody that wants it. And I think it's just the best thing.
One last final question. A lot of the dentists listening to you right now, a lot of people in Dental Town, one of the biggest groups on there is people trying to get their FAGD and the Academy of General Dentistry and their MAGD. How much of these hours all contribute to AGD, FAGD, MAGD?
Well, they're all AGD credit. Now, that's one aspect that I'm probably not the right guy to ask. Okay. But I'm going to say that I believe all of them do, because
all didactic, all hours of CE by accredited. Are you guys accredited by the ADA and AGD? So all those hours be accredited, and those aren't the hardest to find. What they all whine about is the fellowship is 500 hours, all just online or classroom. But to get your mastership is 600 hours, and 400 of those hours have to be participation hands-on courses. So the most sought after course on is hands-on participation. In fact, you want to know what's so embarrassing about the MAGD? I got my MAGD, but when you go to all the big annual meetings, you'll find all these dentists taking a hands-on for like removable partial denture, removable denture, and they've taken the course 8 times because they have to have like 40 hours in this subject, and it's a 3-hour course. So every year they go, and the instructors up to like, oh yeah, the whole back 3 rows that they come. I've taught everyone on this exact course 4 times. So if you're in your marketing, I would dissect the what's really valuable with what you got besides implantology is the hands-on participation courses, and I think Pinky does a great job dissecting out what hands-on participation you'll get in a week-long curriculum. And I know people that specifically go with just there as opposed to all the other ones because they could get so many hands-on participation. Those are the unicorn hours that they need.
Okay.
But
Okay.
but
That in
Jay,
mind.
seriously, man, if you already got the content, put some of them up on Dental Town. Just consider it marketing. Just
All right. I'll reach out to you. We'll work something out like
Yeah.
that. I think it's a great idea. We'll be able to reach a lot of people.
And
That'd be super.
thank you again for all that you've done for dentistry, and thank you so much for coming on my show today.
Well, I appreciate it, Howard. Thank you very much.
All right.